Let's dive straight into this hyper-dense, high-yield explainer. Our absolute goal today, building rapid, infallible pattern recognition for those tricky board-style clinical vignettes. We're targeting a perfect 270-plus step 2 CK score here, so we're focusing entirely on clear immunological mechanisms, definitive timeline boundaries, and high-yield diagnostic differentiators. No fluff, just the facts.
Here is our strict roadmap for this explainer. First, the 4 hypersensitivity types. Second, transplant rejection mechanics. Third, graft versus host disease. And finally, we'll wrap up with board-style traps. We're moving linearly from pathophysiology to definitive timelines, ending with the exact traps test writers use to steal your points.
All right, Module 1, the 4 hypersensitivity types. We're starting by establishing the strict immunological mechanisms governing these reactions. Master these foundations, and I promise you, the clinical presentations are just going to logically follow.
When we consolidate the defining antibodies or cells responsible for each of the 4 hypersensitivity types, a really clear progression emerges. Notice the pattern here? Types 1, 2, and 3 are all entirely antibody-mediated, utilizing IgE, IgG, or IgM. But type 4, it stands completely alone as a cell-mediated process. That is a huge differentiator.
Let's break them down. For type 1, immediately link the IgE-mediated mechanism to the rapid onset of preformed mediators. The antigen cross-links preformed surface-bound IgE on mast cells and basophils, which triggers the massive release of vasoactive amines, like histamine. This is exactly why it is known as first and fast. It's a mechanism that directly dictates the clinical presentation of life-threatening events like anaphylaxis, asthma, and acute urticaria.
Now, what's really fascinating is the direct contrast between types 2 and 3. They both heavily involve IgG and IgM, but the ultimate target is the key differentiator you need to remember. In type 2, the antibody binds directly to an antigen on a specific enemy cell, leading to direct cytotoxic destruction via complement or macrophages. This is exactly what drives acute hemolytic transfusion reactions, autoimmune hemolytic anemia, and Goodpasture syndrome. But in type 3, antigen-antibody complexes form in the bloodstream and then inappropriately deposit into your tissues, like your joints and glomeruli, where they activate the classical complement pathway. It's this tissue deposition that drives systemic diseases like serum sickness, post-streptococcal glomerulonephritis, and lupus nephritis.
To put that into perspective, consider a classic type 3 serum sickness vignette. Historically, this was seen when patients received horse-derived diphtheria antitoxin. But today, we usually see it when a patient receives a non-human protein, like botulism antitoxin, and those circulating immune complexes start to form. Because it takes time for these complexes to actually deposit and trigger the inflammatory cascade, the patient won't react immediately. Instead, they develop a fever, an urticarial rash, and severely painful arthralgias about 1 to 2 weeks post-exposure.
Moving on to type 4. So, the absolutely crucial point for type 4 is that it is entirely T-cell mediated and delayed, completely bypassing antibody involvement altogether. Sensitized T lymphocytes encounter the antigen, release lymphokines, and activate macrophages. Because it doesn't rely on preformed antibodies, it's the fourth and final delayed response. When you think type 4, think contact dermatitis, the tuberculin skin test reaction, and importantly for our next topic, chronic graft rejection pathways.
Which brings us perfectly to Module 2. Transplant rejection mechanisms. Moving seamlessly from foundational immunology, let's take those mechanisms and map them to the definitive timelines of solid organ transplant rejection.
Mapping these mechanisms builds a definitive diagnostic timeline that you absolutely have to own. Anchor these exact boundaries in your mind. If rejection happens in minutes to hours, it's hyperacute. That's driven by preformed host antibodies attacking donor HLA or ABO antigens, causing immediate vascular thrombosis and ischemic graft necrosis. If it happens in weeks to months, it's acute, which is driven by a host T-cell cellular response or a donor-specific humoral response. And if it happens over months to years, that's chronic, characterized by progressive, irreversible cellular intimal fibrosis and vascular occlusion.
Now, the highest yield takeaway here is how you manage the middle of that timeline. Acute rejection presents on a biopsy with a dense, reversible lymphocytic infiltrate. Because it is highly cellular and inflammatory, you've got to treat it immediately with high-dose corticosteroids, anti-lymphocyte antibodies, or other immunosuppressants. Do not miss that on test day. All right, Module 3,
Graft versus host disease, or GVHD. We're shifting gears now to a unique complication that is specific to allogeneic hematopoietic cell and bone marrow transplantation. Dissecting the pathophysiology here, we're actually seeing the exact inverse of a typical solid organ rejection. In solid organs, the host attacks the graft, right? But here, we're placing immunocompetent donor lymphocytes into an immunologically compromised host. So, the viable donor T cells detect the host tissues as foreign. They become activated, and they mount a systemic, incredibly aggressive attack against the host's own major histocompatibility complex antigens. Because the donor T cells are systemically attacking the host, you absolutely must memorize this definitive target organ triad. The skin, the GI tract, and the liver are the primary victims. On an exam, look for a diffuse maculopapular skin rash or erythroderma, severe secretory diarrhea indicating enteritis, and hyperbilirubinemia or jaundice pointing to cholestatic hepatitis. Okay, Module 4, Board-Style Traps. Let's aggressively test these concepts by exposing the exact traps test writers are going to use to trick you on exam day. Here is trap number 1, which attempts to panic you into treating a diffuse rash with epinephrine. A patient presents 10 days after receiving botulism antitoxin with a fever, an urticarial rash, and arthralgias. Do you reach for the EpiPen? The answer is absolutely not. You have to recognize this as a delayed type 3 immune complex phenomenon, otherwise known as serum sickness. Test writers desperately want you to see urticarial rash and impulsively choose epinephrine. But remember, epinephrine is strictly reserved for type 1 IgE-mediated anaphylaxis, which happens in minutes, not 10 days later. The actual next best step here is stopping the offending agent, providing supportive care, analgesics, antihistamines, or in severe cases, steroids. Let's look at trap number 2. A transplant patient is 2 months post-transplant and their organ function is rapidly declining. The biopsy reveals a dense lymphocytic infiltrate. The test is going to ask, is this graft failure irreversible? Should you prepare for retransplantation because the graft is completely lost? Use this differentiator to dismantle the trap. A dense lymphocytic infiltrate right at the 2-month mark definitively places this in the acute rejection window. This is a cellular host T-cell-mediated response, and crucially, it is reversible. So no, do not give up on the graft. The next best step in management is high-dose steroids. You only assume irreversible graft loss when you see intimal fibrosis and vascular occlusion months to years down the line in chronic rejection.
Finally, trap number 3. This one requires ruthless differentiation of immediate transfusion reactions based on exact clinical markers. Minutes into a transfusion, the patient crashes rapidly with severe wheezing, urticaria, and hypotension. Both hemolytic and anaphylactic reactions can cause rapid hypotension, so how do you quickly distinguish them?
Notice the specific clinical contrast here. An acute hemolytic reaction is a type 2 hypersensitivity due to ABO incompatibility. It's going to present with clear signs of red blood cell destruction, things like hemoglobinuria, pink urine, flank pain, and fever. However, this vignette specifically gave you bronchospasm, wheezing, and urticaria. Those are the absolute hallmarks of extensive mast cell degranulation, which is a type 1 IgE-mediated anaphylactic reaction. Test writers love testing this because patients with an underlying baseline IgA deficiency are at an exceptionally high risk for this specific anaphylactic response to blood products. You stop the transfusion immediately and give epinephrine. True mastery of this material comes not just from knowing the facts, but from understanding exactly how the exam will try to use those facts against you. Master the mechanism, own the timeline, and your diagnostic accuracy becomes absolutely bulletproof. So, armed with this pattern recognition, what clinical trap will you dismantle next?